patient becomes acutely critically ill, one of the first things we do is do a blood gas looking for evidence of metabolic acidosis. Metabolic acidosis is a term that is used by all doctors, despite the fact that most of them don't really understand what it is, what causes it, and how to treat it. This talk will look at where we stand with metabolic acidosis in 2025, how the thinking about this has changed over the past quarter century or so, and why a lot of the things you think about metabolic acidosis are in fact incorrect. Because acid-base is a dynamic problem associated with point-of-care tests, it can only be understood in the clinical realm. So I'm going to start with a clinical scenario. Denise is not a real patient, she's an amalgam of several patients. She's 44 years old. She was brought in by her family, confused and incoherent, weak and unable to stand. She was tachycardic and hypotensive with a 3-day history of severe nausea and vomiting. She has been unwell for 2 weeks. There's a history of weight loss, there's a history of polydipsia and a lot of stress in her life. Now, if Denise comes into the hospital with this picture, as soon as she arrives in the door, someone is going to do a blood gas on her because blood gas measurement is the most robust and reliable point of care test. It can be done either on venous blood or arterial blood, and you can identify problems with oxygenation, ventilation, and metabolism. And most critically ill patients will have an anomaly of one or more of those. Now, this is Denise's blood gas after 1 hour, and when you eyeball the blood gas, instantaneously you will identify that she's really sick. And although the pH appears to be relatively normal and pH is not a great marker, you will identify that she's hyperventilating, and the combination of the low PCO2, the low bicarbonate, and its derivative, a large base deficit, represents metabolic acidosis. You will rapidly develop a differential diagnosis without further data. Metabolic acidosis is associated with accumulation of negatively charged mineral or organic particles in extracellular fluid. These are anions. The anions in question are chloride, ketones, lactate, or a variety of different metabolic or poisonous junk products. Sometimes these are known as renal acids, but generally they are particles that carry a negative charge that accumulate in acute critical illness. The increase in the amount of anions relative to cations results in a fall in the pH that triggers hyperventilation, pushing the pH back up with the CO2 drops, as does the bicarbonate. The bicarbonate will fall in a 1 milliequivalent to 1 milliequivalent ratio to the rise in other anions. A neat way of looking at that change in bicarbonate that is standardized for temperature and carbon dioxide is to use the term base deficit, originally described by Sigurd Andersen and colleagues in Copenhagen in the late 50s and early 60s. I think the base deficit is the best screening tool for metabolic acidosis. Acidosis occurs when there is disruption in homeostatic water dissociation equilibrium caused by a relative increase in the extracellular anions over cations. Most doctors understand this as a widened anion gap. As the anion level goes up, the bicarbonate level drops. The modern understanding of acid-base comes from the work of Peter Stewart, a Canadian physiologist who worked at Brown University. He used very complex mathematical models to calculate out the impact of different variables on acid-base chemistry and determined that only 3 things can impact the hydrogen ion concentration or activity of blood. The first thing is the partial pressure of CO2, and no one in the world will argue with that. The second thing he termed the strong ion difference. And the third is the concentration of albumin. The strong ion difference is the difference in charge carried by all the fully dissociated cations minus all of the fully dissociated anions. On the cationic side, that is sodium, potassium, magnesium, and calcium. On the anionic side, that's chloride, beta hydroxybutyrate, acetoacetate, and lactate. The difference in this strong cation to anion difference is about minus 44 milliequivalents per litre. I say milliequivalents because I'm referring to valency, not millimoles, which refers to quantity. In acid base, we talk about milliequivalents. And that charge is carried by bicarbonate, albumin, phosphate, and unmeasured anions. If the strong ion difference decreases, there is an excess in strong anion over strong cation, and metabolic acidosis ensues. These are the standard metabolic acidoses that you are all familiar with. Hyperchloremic acidosis, you'll be familiar with that as a non-GAP metabolic acidosis. Incidentally, I don't know why anybody says non-GAP. All non-GAP acidoses are caused by hyperchloremia, so just please call it hyperchloremic acidosis. And then the others, lactic acidosis, ketoacidosis, and acidosis caused by a medley of unmeasured anions. If the strong ion difference increases, there is a surplus of cation over anion and metabolic alkalosis exists. This may happen from excessive diuresis, and it's known as contraction alkalosis. Albumin carries a negative charge, so reduction in the serum albumin level is associated with metabolic alkalosis, hypoalbuminemic alkalosis. This happens in pretty much all critically ill patients. It happens because of dilution of albumin with intravenous fluid that doesn't contain albumin, but it also happens because the liver stops making albumin in acute critical illness. It's a negative acute phase protein. To summarize this, metabolic acidosis is caused by hyperchloremia, hyperlactatemia, lactic acidosis, hyperketonemia, ketoacidosis, and unmeasured anion acidosis associated with metabolic junk products, usually seen with acute kidney injury or severe tissue injury. Let's go back and look at Denise's blood gas and other labs. You'll note on the blood gas now we have more information. Her glucose is 17 millimoles per litre. This is very high. She also has a lactate of 7.6 millimoles per litre. Her sodium and her chloride are slightly abnormal. Her albumin is normal. That lactate of 7.6 is not sufficient to explain the bicarbonate of 7.7. Very simply, if you just add the lactate to the bicarbonate, it only gets you up to about 14 or 15. So there are unmeasured anions present in the system. The anion you're looking for is beta-hydroxybutyrate, ketones. If you're looking for ketones, don't measure them in the urine. That only measures acetoacetate. Most of the ketones in the body are beta-hydroxybutyrate, and that can only be measured on a blood test. And in our clinical practice, in any situation where there's a base deficit of minus 5 milliequivalents per litre or greater, we always check ketones, and it is astonishing how often we diagnose ketoacidosis. Now, the medical team in the emergency room see Denise and decide that despite her being 44 years old and slender, she must have first onset diabetic ketoacidosis because of the extremity of her acidosis. And they start her on a guideline or a protocol that is based on international standards. Over the next number of hours, she receives 6 litres of isotonic saline solution in the emergency room and on the ward. Over the course of 12 hours, her ketones and lactate cleared. They went down to 0. But the acidosis persisted, manifested by a low bicarbonate and a base deficit. That was associated with a spectacular rise in her plasma chloride by 30 millimoles per litre. Some of the change in the chloride will be associated with the removal of other osmoles from plasma, such as the glucose, lactate, and ketones, but this is a very dramatic increase in the plasma chloride. Because the only acid-base abnormality currently present is hyperchloremia, and she's still acidotic, this is hyperchloremic acidosis. Let's look at hyperchloremic acidosis in a little bit more detail. I first came across this problem hyperchloremia associated with resuscitation with isotonic saline solution from this paper that was published in Anaesthesiology in 1999. Patients undergoing gynecological surgery were randomized to two groups. One group got a compound sodium lactate solution, as Hartmann's or lactated ringers. The other group got isotonic saline solution. Each group received 30 mL per kilo of fluid during the operation. These are the results. If you look very carefully, you will note that the patients who were given isotonic saline had a dramatic increase in their plasma chloride associated with a fall in the pH and an increased base deficit. That was directly related to a reduction in the strong ion difference consequent of hyperchloremia. Hyperchloremia is associated with metabolic acidosis due to reduced strong ion difference, and it's usually caused by the administration of isotonic saline solution. Why is this? A 1 liter bag of isotonic saline solution contains 9 grams of salt. That includes 154 milliequivalents of sodium and 154 milliequivalents of chloride. In the extracellular space, the normal concentration of sodium is 140 milliequivalents and chloride 105 milliequivalents. So the sodium to chloride strong ion difference is 35. That's a positive number, plus 35. 15 liters of extracellular fluid contains 2,100 milliequivalents of sodium and 1,575 milliequivalents of chloride. If we take away 3 liters of extracellular fluid and replace it with sodium chloride, then we're going to add in 462 milliequivalents of sodium and 462 milliequivalents of chloride. By adding that to the sodium and chloride that's in the 12 liters of extracellular fluid, now bringing us up to 15 liters, the new concentration of sodium will be 143 and chloride 115. The sodium minus chloride strong ion difference is now 28. When the strong ion difference falls, there is metabolic acidosis, and this is the mechanism of hyperchloremic acidosis. It won't be as bad as it might look on the surface because the albumin is also diluted simultaneously, and that albumin dilution effect will bring the base excess up by 2.5. So ultimately, the equivalent base deficit will be minus 4.6 milliequivalents per liter. Does this matter? It does. We've had 25 years of extensive research looking into acquired hyperchloremia, and it is my belief that acquired hyperchloremia with a chloride level of more than 110 millimoles per liter is likely harmful. It is known to reduce splanchnic blood flow, increase the risk of acute kidney injury, increase the need for kidney replacement therapy. It may increase mortality. And the thing is, it's unnecessary because in any situation that you might think of giving saline, you can give a balanced solution instead. And balanced solutions look more like extracellular fluid. They include sodium lactate solutions, Hartmann's or lactated ringers, or more modern, fully balanced solutions such as Plasma-Lyte or Normasol. Many studies have been done looking at the outcomes of patients who are randomized to get saline versus, for example, Plasma-Lyte. And in general, most of those studies have shown a signal, albeit fairly weak, that patients who got Plasma-Lyte did better. There were 2 relatively big studies that happened in and around the time of COVID and were never really truly finished. They were published in the New England Journal. They were the PLUS trial and the BASICS trial, and they showed equivocal results. But when you actually dig into those papers, you will find that the patients who were supposed to get a lot of fluid to change their chloride got very little fluid indeed, and in fact, their chlorides didn't change. They were studies that looked at thinking of giving patients IV fluid rather than fluid studies. Nevertheless, a group published in 2022 a systematic review and meta-analysis that included all of the big trials of saline versus Plasma-Lyte or other balanced solutions in acute critical illness. And they looked at 90-day mortality, including 35,000 patients. And they were able to determine that there was an 89.5% probability that the use of balanced solutions versus saline reduced mortality. There was no evidence to support the continued use of saline solution in any setting except traumatic brain injury, principally because very little research has been done on isotonic balanced solutions in that setting. Moreover, what about the situation that Denise found herself in? There is clear evidence that balanced crystalloids are associated with less acidosis and a shorter stay in critical care in diabetic ketoacidosis, principally because the patient's acidosis resolves quicker because they don't get hyperchloremic. There's no evidence that hyperchloremic diabetics have worse long-term outcomes or increased mortality. They just stay longer in critical care. In summary, if you're someone who uses isotonic saline as your routine resuscitation fluid, perhaps this will give you pause to think about those other fluids that are commonly used by anesthesiologists and surgeons: balanced solutions, lactated ringers, Hartmann solution, Plasmolite. I'm now going to move on to what I believe is the critical care molecule of the century so far, driven principally, and for reasons that I will explain in a minute, by the Surviving Sepsis campaign. This much maligned and misunderstood molecule is lactate or lactic acid. Hyperlactatemia associated with metabolic acidosis, lactic acidosis, is a powerful biomarker of acute critical illness. It does not cause critical illness, it just goes up when patients get really sick, and the higher the lactate goes, the sicker the patient is. The reason why the lactate goes so high is because of the massive amount of circulating adrenaline or epinephrine in that patient's bloodstream. The longer the lactate remains high, the worse the patient's outcome. Neither of these points is even vaguely debatable. Lactate is an amazing marker that will tell you how sick your patient is in the acute phase of critical illness, not the chronic phase. Lactate is the major product of carbohydrate metabolism, and it's a universal energy source. Just about every doctor I know and virtually all healthcare professionals believe that these are the pathways for carbohydrate-based cellular energetics, and that lactate is only produced when there is no oxygen available to generate pyruvate. This is demonstrably incorrect, and that has been known to be incorrect for decades. Lactic acid is a glucose molecule cleaved in half. Due to its low pKa, it is always dissociated into lactate at physiologic pH. We produce an enormous amount of lactate in our bodies every day, derived from carbohydrate metabolism. At least 35% of all dietary glucose and possibly 100% of glucose is converted into lactate. Our bodies manufacture between 1.25 and 2 moles of lactate per day. On average, 1,500 millimoles of lactate. Where does it all come from? It comes from tissues that produce a lot of lactate, the most important of which are red blood cells. Red blood cells do not contain mitochondria. They have to squeeze into the smallest blood vessels, and mitochondria are big organelles, so they sacrifice the mitochondria for convenience. Consequently, glycolysis is the main source of energy production in red blood cells. If red blood cells have to work harder to drive oxygen to the tissues in any stress situation, then they make more lactate. We also make lactate in our skin, in our bowel, in our brain, in our skeletal muscle. And in the body, according to George Brooks, there are 2 types of tissues. There are lactate-producing tissues and lactate-consuming tissues. Brooks posited that there is an energy shuttle process going on in the body. Lactate is made by, for example, red blood cells, and they generate lactate because they have no option but to do so. But that lactate is very high value because it's already partially metabolized. And so if it goes out into the circulation and is delivered to other tissues, it can be rapidly inserted into the Krebs cycle and used for very efficient energy production. And if you think about it, lactate is partially metabolized glucose. The hard work has already been done. As a consequence, you should see glucose as a universal substrate and lactate as a universal fuel. Muscles, including the heart, will preferentially burn lactate if it is around over carbohydrates and fats. The lactate that is surplus to requirements for energy is sent back to the liver, where it undergoes gluconeogenesis in the process known as the Cori cycle. Subsequently, the glucose goes back into circulation to feed the red cells, the brain, and other tissues. In general, as a consequence, hyperlactatemia is usually associated with hyperglycemia. And the reason for this is that hyperlactatemia is principally driven by increased circulating epinephrine or adrenaline. Adrenaline increases cardiac output, oxygen delivery, and oxygen consumption. Adrenaline increases the conversion of pyruvate to lactate by lactate dehydrogenase. Adrenaline antagonizes insulin and increases glycogenolysis. Adrenaline reduces splanchnic blood flow, reducing hepatic clearance. Hyperlactatemia is associated with increased production of lactate and reduced metabolism. Normally, the lactate clearance capacity exceeds lactate production in the body. But in the setting of hypovolemic shock, for example, in trauma or where patients bleed significantly for other reasons like esophageal varices, the production of lactate increases as a consequence of reduced oxygen delivery. And because of intense vasoconstriction and loss of unstressed blood volume, there is less flow into the splanchnic circulation and clearance capacity is reduced. The plasma lactate level increases. If we come along and resuscitate the patient with blood products and we de-stress the patient, for example, with opioids, then the lactate production falls back down to somewhere just slightly above normal. The blood flow is restored to the liver, so the clearance capacity increases, and then the plasma lactate level falls gradually. It doesn't fall instantaneously because the body continues to make lactate all the time. On the other hand, in sepsis, there is a dramatic increase in lactate production driven by adrenaline. So there's normal or high oxygen delivery to the tissues. This is known as aerobic glycolysis. The lactate clearance capacity may be normal, but because the production is exceeding clearance capacity, the plasma lactate will rise. And it's a good biomarker in sepsis, but it's neither sensitive nor specific. So, working the problem as a physician at the bedside where you see a patient with a lactic acidosis, you have to try and figure out what's going on with the patient. Has there been a trauma or is there obvious bleeding? You check the hemoglobin, although that can be unreliable in the setting of intense vasoconstriction, and the mixed venous oxygen saturation, which is a good marker. Anything under 50% is a bad sign. You control the source and resuscitate the patient with blood products. If it's not bleeding or trauma, consider sepsis. Look for an obvious source and then signs of sepsis, for example, a high white cell count, high procalcitonin, high CRP. There should be other signs, of course, tachypnea, hypotension, a fever, etc. In the situation, control the source, resuscitate the patient with a modest amount of crystalloid. If it's not sepsis or bleeding, there's something weird going on. You should consider liver dysfunction, a toxic cause such as metformin, bowel ischemia, or medley other problems associated with poisoning. It is important to point out that despite lactate being a great biomarker of acute critical illness, something that's used in trauma, something that's used in sepsis, it is not a particularly good endpoint of resuscitation. There is this whole lactate clearance movement out there who believe that to clear lactate, you need to fluid resuscitate the patient with a lot of fluid or give them dobutamine or dopexamine. I don't really understand what the thinking is behind this, because often the fluid that's given to clear lactate is lactated ringers. And in any case, how is the lactate cleared this way unless the patient is profoundly hypovolemic? To clear lactate, you need to reduce production and increase metabolism. And there is no doubt that in early sepsis and in early trauma or bleeding, that giving the patients a lot of fluid appropriately, using a goal-directed approach will improve overall dynamics and reduce the lactate. But just giving a patient fluid because their lactate is high is a fool's game. One of my favorite studies is the Andromeda shock trial, where they looked at capillary refill time versus fluid resuscitation with lactate. And they found that giving a little bit of fluid based on capillary refill was, if anything, superior to lactate clearance. The classic trial that was revisited looked at outcomes in all shapes and forms, from lactate-driven resuscitation to standard resuscitation, and could find no basis that lactate was a useful endpoint of resuscitation. And where it really becomes a problem is that there is a culture of delivering boluses of fluid indiscriminately to patients with modest lactate bumps, irrespective of the cause, and it's a bit like whack-a-mole that ultimately results in patients getting fluid overloaded with associated complications. Don't give fluid just because the lactate has gone up to 3 or 4. Examine the patient and see what's going on. In particular, if the lactate is rising in late critical illness, trauma, surgery, or during the recovery phase of the stress response, it might be a good sign. In this setting, hyperlactatemia is likely an important component of tissue repair and regeneration, including angiogenesis. It is known that rapidly regenerating cells produce a lot of lactate. That's known as the Warburg effect. And white cells contain very few mitochondria. There is an oxidative burst. It's part of cellular immunity that promotes glycolysis and will drive up the lactate. Indeed, although it's quiescent at the moment, there was some nice research done 10 or 15 years ago looking at giving sodium lactate solutions in hypertonic formats to patients with traumatic brain injury in the belief that the lactate acted as a fuel for the brain. Every ICU nurse will tell you that when they are hanging 50% dextrose on patients for hypoglycemia, the patient does not have long to live. A high lactate and a low blood glucose is an ominous sign, and this has been known for generations. In any situation where the lactate is high and the blood glucose is low, remember I told you they should go up together, the patient is in trouble. And the reason why this happens is because the liver is a major organ for glucose metabolism. It generates glucose from amino acids via gluconeogenesis. It maintains and distributes glucose in glycogen. It also converts lactate back to glucose. If the liver is damaged or dying or dysfunctional, this doesn't happen. And as a consequence, the lactate levels rise because they're not being cleared, and the blood glucose falls because it's not being replenished. It's an ominous sign. Let's look at ketoacidosis. The majority of doctors continue to prefix the word ketoacidosis with diabetic, despite the fact that in our practice, the majority of cases of ketoacidosis occur in patients who are not type 1 diabetics. We have a tendency to think about energy consumption in terms of exercise, but actually exercise doesn't change energy consumption all that much. We need 80 to 100 kilocalories per hour just to keep our bodies running smoothly. Food ingestion is intermittent, but blood glucose must be kept between 4 and 8 millimoles per liter. Below 4, there's a problem because several of the tissues of our body are entirely glucose dependent. Above 8, the glucose becomes toxic and causes osmotic diuresis. Insulin regulates metabolism by controlling blood glucose principally, but also changing the way proteins and fats are metabolized depending on the blood sugar levels. So when glucose is abundant, the body will use carbohydrates as its principal source of energy. Insulin will send glucose into glycogen and into cells, particularly fat cells. Fat metabolism is suppressed with insulin. When insulin levels are low, most of our energy is derived from fat metabolism. As part of this process, the liver makes ketones. Like lactate, they represent partially metabolized energy product. The liver processes the fat so the muscles don't have to. We produce 2 to 4 moles of ketones per day. Ketones are a phenomenal energy source. When insulin levels are low, dietary circulating carbohydrates are used principally for cells that are glucose dependent. The body burns fats for energy. As part of that process within the liver acts as a net exporter of energy by repackaging partially metabolized fats into ketone bodies. Those ketone bodies are acetoacetate and beta-hydroxybutyrate. These particles are then exported to energy-hungry tissues such as skeletal muscles. They enter cells via monocarboxylate transport channels and are reverse engineered into acetyl coenzyme A and fed into the Krebs cycle. This process is slowed by the ingestion of carbohydrates that results in a rise in insulin levels. Normally, ketone production and utilization goes under the radar and very few ketone bodies are detectable in plasma. However, if carbohydrate intake is massively reduced, such as on a low-carb diet or during starvation, people develop ketosis. The ketone level is usually lower than 2 millimoles per litre. When there is an absolute deficiency of insulin or there is massive loss of carbohydrate from the body, for example in the urine, then ketogenesis may occur unopposed by insulin and driven by adrenaline and other stress hormones, accumulating as strong anion in the plasma, resulting in ketoacidosis. In this setting, type 2 diabetics can develop hyperglycemia and ketoacidosis, although that picture is more complex than with GKA that you may be more familiar with. Now let's revisit Denise, the 44-year-old woman with acute ketoacidosis associated with hyperglycemia and hyperlactatemia. The original diagnosis was diabetic ketoacidosis, but we did a HbA1c on her and it was within normal limits. We also noticed that she had a raised MCV and some liver enzyme derangements. On further questioning, the patient admitted that she had been drinking a lot recently and had not really been eating. So Denise's diagnosis was alcoholic and starvation ketoacidosis. Starvation ketoacidosis can occur on its own, but it can also occur in the setting of alcoholism. Alcohol, which is really ethanol, is a good source of energy. There's 7 kilocalories per gram of alcohol. Ethanol is metabolized in the liver to acetaldehyde and subsequently to acetate. That can be exported around the body where it is compounded into acetyl coenzyme A. Acetate is a component of TPN, total parenteral nutrition. It's also the main anionic buffer in plasmolyte. When you ingest carbohydrates, insulin is secreted and it encourages the processing of glucose in the liver and in adipose tissues. Ethanol does not activate the release of insulin. Patients who subsist on alcohol have extremely low insulin levels. Hepatic glycogen stores are low and the pancreas may hibernate. In addition, ethanol suppresses fatty acid oxidation. This is important for people who are on diets. If you're drinking a lot and you're on a low carbohydrate diet, you will not burn a lot of fat because the ethanol is suppressing fat consumption. You're more likely to derive energy from breaking down skeletal muscle. The acetate is used easily as a Krebs cycle precursor similar to ketones, but it's not a ketone. Alcoholics do not develop ketoacidosis if they're still drinking. It's important to note that neither acetate, acetyl coenzyme A, nor free fatty acids can be used to manufacture glucose. In the case of Denise or other patients who have been drinking, when alcohol consumption stops, they go into a state of starvation associated with low calorie intake. This is particularly bad if the patient gets very sick and has vomiting and diarrhea. Because of the extremely low insulin levels and the high glucagon levels, there are low levels of hepatic glycogen from which to demand glucose. As a consequence, the body becomes acutely stressed and goes into a hyperadrenergic state. This causes gluconeogenesis derived from skeletal muscle and also hyperlactatemia from breakdown of glucose. The consequence of this is hyperglycemia that goes around in a vicious circle. Epinephrine adrenaline encourages lipolysis to free fatty acids and then to ketones. Ketones will not be suppressed in the absence of insulin, and ketoacidosis ensues. And this is the picture of what happened to Denise. She was drinking a lot and then became starved, and she developed starvation ketoacidosis. The lactic acidosis was secondary to the stress response. She also developed a mild, unmeasured anion acidosis from hypercatabolism, and subsequently a hyperchloremic acidosis from fluid resuscitation. The treatment for Denise was gentle fluid resuscitation, preferably with a balanced solution, Plasma-Lyte Hartmann's lactated ringers. She needed insulin and dextrose. She needed some multivitamins and lots of food to refresh her hepatic glycogen and to suppress further gluconeogenesis from her skeletal muscle. Her risk of refeeding is relatively low, but you always need to be aware of this in someone on whom you start an insulin infusion. Let's move on and look at another clinical scenario. Teresa, who's 76, had a similar story to Denise's. She was brought in by her family, having had a fall on the bathroom floor. She couldn't get up. She was mildly confused, very thirsty, with a 7-day history of flu-like symptoms, vomiting and diarrhea. She had a history of type 2 diabetes. She had coronary arterial disease, stents. She's tachycardic and hypotensive. This is her blood gas, and it's scary looking. You can see that she has severe acute metabolic acidosis with a very low pH and a very high lactate. If you only saw this blood gas, you might summarize that the patient was septic or bleeding, but this information is inadequate. Also, at this stage, the patient was wide awake and talking to us. So let's look at the remainder of her labs. You will note the sodium is low, the potassium is low, the chloride is low, the hemoglobin is low. But she also has a beta-hydroxybutyrate of 4.3, an albumin of 31, a urea that's very high, and a creatinine that's very high. So there are a whole pile of different acid-base abnormalities going on here. If you were to take the standard approach and do an anion gap, it would be extremely unhelpful because there are multiple alkalinizing and acidifying things going on simultaneously. There are all kinds of other problems with the anion gap. Principally, nobody's quite sure what the normal gap is, but also part of the gap is the serum albumin, which drops in acute critical illness or when you've given fluid. Now, I have to state that for the past 25 years, I have not used the anion gap routinely in my practice. Instead, I've used a modification of the Stewart approach that was originally proposed by Sheldon Magder and then adjusted by Fensel and ultimately simplified by David Story. And what this does is that it looks at all the acidifying and alkalizing processes going on together. And eventually, at the end of that process, you're able to work out the amount of negative anionic charge associated with unmeasured anions, because pretty much everything else is measured and calculatable. The first thing that you try and calculate is the sodium, chloride, and water effect. And the simple version of this is the sodium minus the chloride minus 35. That's the measured sodium and chloride. Then you calculate out the albumin effect, 42 minus the measured albumin divided by 4. That's the amount of milliequivalents per liter of charge on albumin. And then you take the calculated or derived base deficit from the blood gas that's derived from the bicarbonate and subtract the sodium chloride effect, the albumin effect, the lactate, and the beta-hydroxybutyrate. And the result of all of that will give you the base deficit for unmeasured anions. So for Teresa, we had a base excess for sodium and chloride and free water of plus 19. This is a hypochloremic alkalosis. The base excess for albumin was plus 2.5. The base deficit for lactate was minus 20. For ketones, it was minus 4.3. Putting all of those together, the sum of all of those alkalinizing and acidifying processes gave us a base deficit of minus 2.8. The derived base deficit from the blood gas was minus 29, which means that the base deficit for unmeasured anions was minus 26. So this patient had a lactic acidosis, a ketoacidosis, an unmeasured anion acidosis, hypochloremic alkalosis, and hypoalbuminemic alkalosis. What she needed was two things. She needed to be dialyzed for her acute kidney injury, but she also needed her euglycemic ketoacidosis to be treated with insulin and dextrose. What caused the acute kidney injury, the unmeasured anion acidosis, the lactic acidosis, the ketoacidosis, etc.? It's likely what happened with Teresa is that she became acutely unwell from perhaps a viral or bacterial infection, and she started vomiting and got diarrhea, but kept taking her tablets. And one of the tablets she was taking is dapagliflozin. Dapagliflozin is a sodium glucose cotransporter 2 inhibitor. These drugs are known as flozins. They're very widely used now in type 2 diabetics, particularly those who can't control their carbohydrate intake. They're also used for congestive heart failure and for some nephropathies. And what they basically do is block glucose reabsorption in the kidneys by blocking the sodium glucose cotransporter receptor in the proximal tubule. So sodium and glucose are wasted in the urine, there's glycosuria, and there's some reabsorption of chlorides. The patients are often slightly hyperchloremic. Not all of that sodium is wasted. Some of the sodium is reabsorbed via monocarboxylate transporters alongside lactate and ketones. So in the setting, the patient can lose a lot of glucose, but they will always reabsorb lactate and ketones, and that's part of why they get a big acidosis. Generally, patients who are on SGLT2 inhibitors have a liver full of glycogen. And so despite taking these drugs that waste glucose while fasting, they will maintain their blood glucose for up to 48 hours as all of that glycogen store is emptying. Then they need to get into gluconeogenesis to maintain a plasma glucose of more than 4 millimoles per liter. This is problematic and it causes a stress response, and the stress response causes a lactic acidosis. The patient also is slightly hyperchloremic, so that's a double acidosis. And because of all that adrenaline, there's lipolytic activity and an increase in the ketone level. So the patient typically develops ketoacidosis, lactic acidosis, and hyperchloremic acidosis. And if they become profoundly unwell like this and develop acute kidney injury, the pH falls very profoundly. The management of a patient such as Teresa with this euglycemic ketoacidosis, I don't like calling it euglycemic diabetic ketoacidosis because it's the same kind of picture as we see in patients who have starvation, and also many of the patients who are given these drugs are not diabetics. The treatment is to give her intravenous dextrose and insulin immediately. That will rapidly reverse the ketoacidosis. Resuscitate her with a balanced solution, not saline, because they're often hyperchloremic and we don't want to worsen the hyperchloremic acidosis. And indeed, if the chloride is more than 120 millimoles per liter, I will give this patient sodium bicarbonate. Is one of the few situations that I use sodium bicarbonate in hyperchloremic acidosis. Of course, the best way to treat euglycemic ketoacidosis is to avoid it by encouraging the patient to avoid taking their flozins if they're not eating. It takes about 5 half-lives for these drugs to stop working, so it should be discontinued in advance of surgery. For ambulatory surgery, for simple day case surgery, for patients who can eat post-op, I don't think it's a problem if they've taken these drugs on the day of the operation or even the day before. You can always put them on an insulin infusion. Where we tend to run into trouble is the emergency patient who's on the list for a laparotomy, that's been hanging around the hospital for a couple of days, fasted, receiving only resuscitation fluids, not glucose-containing maintenance fluids, getting progressively more and more ketotic, and they may arrive in the operating room just as the ketoacidosis is starting. So any patient who has a history of being on SGLT2 receptor antagonists, even if they say they've stopped them and they've been fasting for a while, please check their blood ketones. Key points. Acid-base remains a really effective screening tool in the 21st century. Aside from identifying problems with ventilation, acid-base abnormalities identify major metabolic upset and can identify and quantify acute critical illness. Avoid large volume resuscitation with saline. It is harmful. Measure lactate and ketones and plug them into your anion gap if you insist on using it. Do not perform drive-by saline assaults for modest hyperlactatemia. If the base deficit is -5 or greater, always check ketones. Beware of SGLT2 receptor antagonists in perioperative patients. If you found this presentation useful, please check out my blog at ccmtutorials.org or my series of videos that cover acid base at CCM Tutorials on YouTube. Thank you.